little bit stuck. Anyway, let me just start from telling you a few things. Good morning, everybody. It's good to see so many familiar faces and new faces that I have not seen before. The next thing that I have to say is that thank you to Mark Gibson and INSMED. We have this program today, okay? We have a debt of appreciation for them to do this possible, okay? With the help and with the help of the community, we cannot have these meetings. And we need all these meetings. All these are learning for all of us, for all this disease that we have, because one can lead to another one, okay? So thank you to them. We really do appreciate. The next thing that I have to say is to the club members, all the people that have done all this, all of you that participate from this, I really do appreciate your support. You are the pillar of this club. Keep going. So by all means, keep doing it. I really do appreciate that. With that, I'm gonna leave this to Mark. You have a couple of words.
Oh, yeah, thank you so much. And thank you for letting us come in here and really educate on bronchiectasis and a treatment that was recently approved. I just want to talk about a couple educational pieces first on bronchiectasis that we can provide. And then Dr. Salerno should be in here shortly. Oh, sure.
If you don't mind.
Is that?
I'm sorry about that.
No.
You can.
Okay. Tell me if you can't hear me, I'll speak up. But this book is, it has just education about bronchiectasis, what it is. One thing that is in one of the pages in the back is a kind of a symptom tracker that kind of talks about some of your symptoms you might be having and can share it with your doctor. And you can have that conversation about the disease. So that's in the back of the book. You'll see a little, on one of the pages, you'll see that little drop-down area. It's in there. Another thing, when you're reading through this, in the back, there's a QR scan code. So a lot of your phones, you have that gives QR codes. There's a book that was written by patients. It's called Seen, that INSMED, my company, put together for patients. And that book can be sent to you for free. It's a hardback book. It's a really good book, and by all means, if you want to learn more about it from a patient standpoint, it can talk about other things too, like DME supplies and other things besides just the symptoms of the disease. So that's one thing we are doing to educate the community regarding the disease. Another thing we're doing is a lot of the offices now have these 3D lungs, which will help, show what bronchiectasis is and kind of how it's affecting your lungs. That's another thing that we do. You will see TV commercials for bronchiectasis, so I'm waiting for one to come on during the Olympics. But it talks about flares and how it's just a burden to live with it. And but fortunately, we have some therapies to treat it. And I'm trying to think if there's anything else we provide for education. There's another paper version of the 3D lung that we do provide offices, which is another tool to really research the areas of the lung that's being affected by bronchiectasis, and it's a drop down. So by all means, if you need any of these books or anything, I have more of them, and I can leave you with a few. But yeah, I really don't have anything else at this point. Anything else you want to share about the club?
Yes. The next person that I want to introduce is Laura. Lara, you have a couple of things to say about our next meeting. Oh, yes. Laura is a person that collaborates with us. She's part of the group for Naples Pulmonary Rehab.
Oh, hi, thank you. Thanks, Oscar. So my name is Laura, and I am with the American Lung Association as a volunteer. And so I've been collaborating with Oscar because he did such a great job along with NCH Rehab of starting this group and this club. So next month, the speaker is going to be on palliative care. Her name is Karen with a Bow. And palliative care is just talking about how you can get extra support when you have a chronic medical condition or a chronic pulmonary disease, because palliative care will work in conjunction with your providers in the community. So it's a great resource to have information on. So I believe Karen is the person that's going to be speaking. And I have information that I'm going to be sharing with Oscar to do a flyer. So that will be the next speaker for March 11th. Thank you.
The next thing that I have to say is that I have to do a great appreciation. I give always to the NCH for support us, for give us all the support. For the pulmonary rehab members, and I want all of you, please give a round of applause to the people that gave us all this support, okay?
I also wanted to say something real quick.
By all means.
I saw your newsletter, and I wanted to touch on this. We had a patient unfortunately pass and had very nice equipment that he wanted to donate. As NCH, I cannot accept donated, but I could use Oscar so he could pay it forward. So I just wanted to thank you guys and let you know that anything you donate through the club will be passed on to other people. I think the lady that received it isn't here today, but it was a very nice high-end oxygen concentrator that we all know how hard they are to get, how expensive they are to keep up with. So I just want to say thank you guys for understanding that we can't personally give it to you guys, but thank you for remembering that we can get it to other people that have needs, because not everybody's in the same tax bracket, and there's definitely a lot of equipment that is no longer needed sometimes, even it's something that you got that you don't want anymore, kind of thing that can be passed forward. So thank you guys for just being a part of that. And
Yes, that actually was a beautiful gesture from the widow, that she bring that equipment, and like she said, like Beverly said, she gave it to NCH and they gave it to us so we can pass that on to one of the club members that it was in need of that equipment. And if anybody knows or have any extra equipment or want to donate anything, by all means, bring it over and we will find somebody that will be in need. Not only on the club, okay? Because I do have some other organization, and I have to thank Rescues and Values as well for the support. Every month, Rescues and Values is the one that provide all the support for all this to be happening as well, okay? So throughout this organization, we provide support to other places and other people. Thank you, everybody.
He should be here any minute, so.
Which is fine. We'll wait for him.
yeah, we have the room till 1, so we're good. And maybe even longer than the rest of us.
One other thing that I want to say is that I put on the table for everybody to be familiar with the club, okay? And then, like I said, I call it, or we call it club to make it more fancy, okay? To make it look like, oh yeah, it's from Naples, it has to be a club, okay? So a group support will be like, okay, well, yeah, it's a group support. But since we live in Naples and we do it in Naples, a club sounds more fancy, okay? And it's more high status. So by all means, go through it. If you have any questions, if you want to subscribe, all the information is here. And going back onto what Beverly said about the equipment that it was donated, that letter, a nice letter that I wrote, it was emailed to everybody on the club for, I don't know. I got a few emails that I've been getting a kickback. I will be sending a text to those people to see if they can send me the right email, because for some reason it's been kicking back with an address that is not found.
I just wanted to mention, since everybody has pens and paper, if you have not, I did some overview on the American Lung Association and the resources that might be available to you. If you go to lung.org, you can then pull up a lot of resources on different diagnoses that for pulmonary conditions, and they have a lot of great information that you can reference. And you can always reach out to me. I consider the American Lung Association Better Breathers Facilitator. I have a number that you can always reach out to me if you need information on anything specific. Okay? So I just wanted to share that. Yeah. Thanks, Oscar.
No, thank you.
So Oscar, what was our first meeting? 'Cause I remember reaching out to you last April about starting the club back up. What was our first official meeting? I'm just curious.
Our first official meeting was, no, actually it was, started on January 2025. That's when we had the first meeting right there where we do our pulmonary rehab, and that was with actual patients that had the double lung transplant. Then after, we have done quite a few meetings every month with Denise and some other people just doing the meetings. But yes, we started on 2025, actually doing it constantly, every
I
month.
thought it was more like April, but yeah, that's fine.
Yes,
It was probably just transplant first and then we did it.
yes. Before of that, we were just doing kind of very sporadic, kind of like every 3 months or something like that. We were doing some of those meetings. Yeah, it's very hard to find this place. If you know, especially if you don't know, most of the people just go right to the main entrance.
They should probably have a sign out there.
Yes.
By meaning, arrow and explain what it is.
And I left a brochure right at the emergency, and I told them that we were going to have this meeting for people to show up this way. Probably got lost. Probably I just tossed that.
This is Dr. Edward Salerno. He's with Millennium Physicians Group. He's a pulmonologist. Some of you may or may not have met him.
Thank you, Dr. Salerno.
He's board certified in internal medicine, pulmonary critical care, and sleep medicine.
So much.
And fun fact, he speaks 3 languages, and you'll have to ask him which 3.
Oh, way to go. Thank you.
We'll have you guess with my last name.
Let's just give a round of applause to Dr. Salerno.
Oh, thank you.
Thank you so much, Dr. Salerno. Thank you so much for being here.
Thank you, appreciate it. So let me see how to advance these. There we go. So I'm going to talk about this new medicine called Bronchiectasis, which is the first and only medicine for the treatment of bronchiectasis that's been out. Can you guys hear me okay?
That are just for the recording.
Okay, so the first and only medicine for bronchiectasis that's been out in probably a couple hundred years, or if ever. We're going to review a little bit about what bronchiectasis is. We'll talk about how this medicine works. We'll talk also about the data regarding the medicine and the safety and the efficacy of the medicine, and also the dosing and how it's taken. If you guys have any questions at all during what I'm saying, just stop me and we'll talk about it. Let me pull this out here. So bronchiectasis is a chronic disease of the lungs characterized by dilated airways where they shouldn't be dilated. And I'll show you a picture of what that means. What happens in this disease is there's lots of inflammation that occurs. this inflammation can lead to infections, can lead to more damage and more destruction of the airway, more dilation of the airways. So kind of a vicious cycle, and I'll review a little bit about that with you. So this is a normal understated. The most common symptoms of bronchiectasis are chronic. So the way as a pulmonologist that we know that patients have the white dot, that's where the nerve, artery, and vein is. And every bronchiole travels with that nerve, artery, and vein. And as the bronchiole gets smaller, that becomes bigger than the associated airway. When the associated airway is the same size or bigger than that white dot, then that's the definition of bronchiectasis. So I talked about the inflammation that happens with bronchiectasis. It's primarily a neutrophilic inflammation. A neutrophil is a type of white cell. So this neutrophilic inflammation can have all sorts of properties in the lung, or damage to the lung. They call that the vicious vortex. It can lead to chronic inflammation, lung destruction, impaired clearance of the lungs. And then this can go in all sorts of different directions. So this vicious cycle is what sets up the dilated airways, the repeated infection, the retention of mucus, inability to clear it, the infections, the dilated airways. So it's kind of a pattern of that occurs over and over and over, and patients can develop worsening areas of bronchiectasis just from this vicious vortex alone. Again, the most common symptom of bronchiectasis is chronic cough and phlegm. So how do we know that a patient is having an exacerbation of their bronchiectasis? Well, what I tell patients is anything above your baseline of symptoms is probably an exacerbation. So a patient say to me, I normally cough up about a teaspoon of phlegm every day, and it's kind of yellowish in color. If they come to me and say, hey, Dr. Salerno, I'm coughing up a tablespoon or half a cup or a quarter cup, and now it's turning rust color, and now I'm feeling short of breath, that's a change from their baseline symptoms. That's probably an exacerbation, and I need to be aware of that. So when patients have 3 or more of these symptoms in 48 hours, and I have to change their therapy, that's essentially considered an exacerbation. I don't want that to happen to patients, because that, as I showed you before, can lead to lung damage and worsening bronchiectasis and more symptoms and infection. So this drug, I mean this enzyme called neutrophil elastase is one of the products that causes a lot of the problems that we see in bronchiectasis. And I'll show you as we go on more how that happens. So neutrophil elastase is in the airways, and it's causing a lot of damage and destruction to the lung. And we can see that patients that have a high volume of this in their lung, they're less likely to have not have events. So if you have a large number of this neutrophil elastase, you're more likely to have events, and you're more likely to have bad outcomes from that. Versus if you don't have a lot of this neutrophil elastase, you're likely to not have very many events, and you're likely to do better than if you had more of this neutrophil elastase in your lung. So Brinsupri is a drug that's going to target this pathway and kind of help reduce some of these mediators. So DPP1 is this enzyme that activates the neutrophil to release that neutrophil elastase. So if we can stop this from releasing neutrophil elastase, we can kind of prevent some of the, or most of the negative actions that we can see on the lung in bronchiectasis. And they drive kind of this bronchiectasis, airway inflammation, and that vicious vortex that I kind of showed you. So this drug, Brinsupri, will bind to this DPP1 and will essentially stop the release of this serine proteases, this neutrophil elastase, with the hope of it kind of helping patients reduce their exacerbations and make them better. So how do we know this? Well, this is the study that essentially got Brinsupri approved. It's the ASPEN trial. It's the largest clinical trial of bronchiectasis. It was a large trial. It has all the catchphrases that we like to see as physicians. International, multi-center, randomized, double-blind, placebo-controlled. So there were 1,680 adults aged 18 to 85, and there were also some adolescents, 41 adolescents aged 12 to 18. And they had to have confirmed non-cystic fibrosis bronchiectasis, so dilated airways, but not because of bronchiectasis. I'm sorry, not because of cystic fibrosis. They had to have at least exacerbations, so we talked about exacerbations, 2 or more in the prior 12 months. And in the adolescent group, they had to have 1 or more in the prior 12 months. All these patients in both groups, they were both, if whatever treatment they were on, hypertonic saline, vest therapy, acapella, they were allowed to be maintained on those treatments. And then they were randomized. So one group got 10 milligrams of Brinsupri, another group got 25 milligrams, and there was a placebo group that didn't receive any treatment whatsoever. So the primary endpoint of the study, what they were mainly looking for was the annualized rate of an exacerbation of bronchiectasis. So are we able to reduce patients' need for prednisone and antibiotics and have those exacerbations that I talked about? The secondary endpoint, they looked at several. One was, how long did it take you to have an exacerbation? The percentage of patients who did not have an exacerbation at the end of the study, at the end of 52 weeks, did their lung function change at all, or did it not drop compared to the placebo group? And what was the likelihood of a patient having a severe exacerbation? A severe exacerbation is any patient that either gets admitted to the hospital for their bronchiectasis exacerbation, or they're in the ICU for this. So we're going to look at all of those. So they had to have all the things that I just talked about. They have to have bronchiectasis, they have to fit in the age group, and they have to have these exacerbations. And there were several exclusion criteria. They couldn't have COPD as their primary diagnosis. They could have it as a secondary, but not as the primary. They couldn't have cystic fibrosis. They couldn't have any immunodeficiency disorder. They couldn't be receiving treatment for bronchopulmonary aspergillosis, tuberculosis, or non-tuberculous mycobacterium. They couldn't be on oxygen for more than 12 hours a day. No smokers. And if they were on systemic steroids chronically, they couldn't be in the study. And essentially, the patients are kind of what we see in daily practice. The average age was about 60, more or less equal female and males, female and white patients, African American, Asians. So kind of what we normally see in practice, these patients fit the criteria of what I would say are what my patients essentially look like. So at the end of the study, at 52 weeks, the Brinsupri at a dose of 10 milligrams reduced the likelihood of having an exacerbation over 52 weeks by 21.1%. The 25 milligram dose reduced that by 19.4%. So we use this, the likelihood of you having an exacerbation, patients in that year, 1.02 patients versus 1.04 patients. In the placebo group, 1.29 patients had exacerbations. So there was a significant, clinically significant reduction in exacerbations compared to placebo. The 10 and 25 milligrams had similar reductions, so not much different as far as the reduction goes. You can see at around maybe 18 to 19 to 20 weeks, the two groups start to split. The gray line is the placebo. You can see they're having more exacerbations. And the 10 and 25 milligram dose, you can see they stay fairly the same, but they don't really, there's no real difference till almost about 20 weeks. Okay, that's when we start to see about a big difference. The time to the first exacerbation, so if you take this drug, what's going to happen? What's the likelihood of you having an exacerbation, and when will that happen? Well, if you didn't take any drug at all, your first exacerbation will be somewhere within 36.7 weeks. If you took Brinsupri 25 milligrams, it'll be at about 50 weeks, and Brinsupri 10 milligrams, it'll be at about 49 weeks. And you can see that this is the time to first exacerbation. So it does prolong that time period for your first exacerbation significantly if you take either the 14 or the 10 or the 25 milligram dose. And what's the likelihood of you going a whole year without an exacerbation? Well, at both doses, 10 and 25 milligrams, there's a 48.5% chance that you're going to be exacerbation free in that 1 year. So half of the patients, almost half the patients in the study group are not going to have an exacerbation in that first year. And in the placebo group, it was only 40.3% of patients. So 40% of them will have an exacerbation free, I should say. Severe exacerbations, I want to caveat that wasn't statistically significant, but there was a difference as far as looking at the placebo group, 0.19 versus 0.14. So the higher the number, more likely to have an exacerbation. 0.14 both in the Brinsupree and 10 and 25 milligram group. This is what I think is also very important. So what I hate as a pulmonologist is my patients to lose lung function. So they come back after exacerbations and they're more symptomatic, more short of breath. We know from other disease states like COPD, whenever you have an exacerbation, you never really get back to where you were before. You have an exacerbation, your function gets worse, your pulmonary function gets worse, and it never really gets back to where it was before. So preventing lung loss, one, preventing exacerbations is important, but two, preventing lung loss is very important. So at the end of the study, in the placebo group, they lost 62 milliliters of air, of FEV1, which is how we measure lung function as pulmonologists. Compared to in the 10 milligram group, 50 cc's of air. However, there was only a loss of 24 cc's of air in the Brinsupree 25 milligrams group. So to put it in percentage, there is a 19% less decline in lung function in the 10 milligram dose versus a 61% less decline in FEV1 compared to the 25 milligram dose. So this is really where the two doses differ. So I showed you before with exacerbations, the doses aren't really that different. They both reduce exacerbations. However, when it comes to lung function loss, it's only really the 25 milligram dose that has this protection factor where it's going to reduce your loss of lung function by 61%. So two benefits that we see with the 25 milligram dose. Side effects, if you look at the placebo group compared to the Brinsupree 10 and 25 milligrams, not much different with upper respiratory tract infections or headaches. There was a mild elevation in liver function with this dose, however, with these doses. However, the company doesn't recommend that we monitor liver functions regularly. It's not necessary that we test you before and after, so we don't necessarily have to do that. Also, a small increased incidence of skin cancers and alopecia. I don't really worry about hair loss, so I'm not really worried about that side effect. There was a phase 2 trial called the Willow trial that was a smaller trial. It was not as many patients, only 256 patients, but it kind of looked at the same thing that I just showed you. So it was both doses with placebo, and the primary endpoint was, again, pulmonary exacerbations over 24 weeks. And again, the efficacy, these drugs did reduce exacerbations, and the safety was similar, except there was a slight increase in this gingival and periodontal disease that we noticed, because it's the way my understanding is this DPP1 can affect the gingiva and the oral mucosa. So if you're on it, you should probably have a dentist or whoever does your oral care just to be aware that you're on this drug that may cause gingival disease. And again, now we have something that can limit this vicious vortex to prevent the inflammation, the lung destruction, the lung loss that we see with bronchiectasis and exacerbations of bronchiectasis. It's essentially one pill, 1 time a day. It comes, I showed you, in 2 doses. You can take it with or without food. If you miss a dose, obviously don't double up on it. Take your next dose at the next time that you will normally take it. Be aware of some of the skin and gingival precautions that I mentioned about. And we're not sure of the use of live vaccines, so try to avoid using a live vaccine until we have more information with this. So again, if you have bronchiectasis, you can ask your healthcare provider, is this drug for me? Will this fit into my regimen of trying to prevent exacerbations, to try to prevent lung loss? And if you're someone that is on antibiotics and steroids kind of regularly throughout the year, because of this bronchiectasis, it might fit in very well to a treatment plan for you. I showed you that it's a safe drug. I showed you the mechanism of action. We talked a little bit about the adverse effects and the dosing. The Brinsupree 25, again, recall it's the only only dose that does have that protection for the lung function for FEV1. I'm not going to go over this again. We just talked about it. Obviously, we have no data in pregnancy, but I think in our population we don't really worry about that too much, or lactation. And then again, it's not indicated for patients under 12 or it hasn't been established for 12 or older. Questions for me about any of that? Yes.
What do you consider an exacerbation?
So if you have a kind of a chronic cough, you bring up a little bit of phlegm, if you can kind of estimate what your cough is going to be like on a daily basis, if you notice one day you wake up and now you're coughing more of a volume than you normally do, the color is different, you have additional symptoms like shortness of breath, that's probably an exacerbation. What I tell patients is any change in symptoms from your baseline, whatever you think is normal for you, if there's something different, that should be a clue for you to call your lung doctor and say, hey, I'm having this symptom. Is there something I should worry about? So a change in baseline from your symptom. Other questions?
Does bronchiectasis ever leave?
Does it get better?
Yes.
No, it never. So when you have a dilated airway, that will never go back to where it was before. Now we can prevent them from getting worse, so we can prevent you from having more bronchiectasis. Most commonly in patients that have bronchiectasis, what I've noticed in my practice is patients will get it if they have recurrent infections. So if it's not genetic, if it's not related to cystic fibrosis, you can get bronchiectasis because you had multiple pneumonias in that area of your lung. You can get it if you have connective tissue disease. Some connective tissue diseases are associated with bronchiectasis. So if there's something that's not driving the bronchiectasis, if it's just having an infection, and we prevent you from having an infection, we'll prevent the progression of it. But we can't make those dilated airways become undilated.
I remember about 75 years ago, I had a bronchoscope, and I was told I had bronchiectasis, and they gave me something, and they had me move to Florida because of the air in New York.
Okay.
And that was 75 years ago. I became an athlete.
Yeah.
Lifeguard. Then I got pneumonia a couple of years ago after COVID. I had double pneumonia.
Yeah.
And I have COPD as a result.
Mm-hmm.
Is there anything that gives you a nexus of opportunity or help or something that might ring a bell between that thumbnail history?
So all I can say is either you probably had very mild bronchiectasis back then, or they might have said to you you had bronchiolitis, and the change in climate might make you better. So you may have some inflammatory lung condition, but it wasn't bronchiectasis. It might have been some other inflammatory lung condition. And then over the years, maybe you had pneumonia and other things that predispose you to having bronchiectasis. You develop bronchiectasis. But early on, maybe what they were saying wasn't accurate. I can't comment because I don't know what it is. Yeah.
Is there any, can you explain the difference between COPD and bronchiectasis?
Yeah, so COPD is a disease of airflow limitation. So you have to have an obstructive lung disease. So when we do a breathing test and you blow out, there has to be obstruction to airflow. COPD does also include emphysema, so dilated airways of lung, which is destroyed airways. This is different because this acts on the bronchioles. So bronchiectasis is specific to the bronchioles. You don't have to have COPD or airway obstruction to have bronchiectasis. In fact, many patients don't have airflow limitation when they have bronchiectasis. They have other symptoms, but they don't. It's not necessary to have COPD to have bronchiectasis. The two can be separate. Yes.
Is there any relationship between BE and pulmonary fibrosis? You didn't seem to mention that disease in your presentation.
Bronchiolitis obliterans, you said?
Pulmonary fibrosis.
Oh, okay.
Sarcoidosis.
Oh, now you're getting into a lecture that I think we'd need another hour for.
Yeah, but I'm wondering if there's a relationship
Yeah.
between
So
the two, or is this completely different?
So separate entities. So pulmonary fibrosis, again, that's thickening of the interlobular septa. That's space between the blood vessel and the alveoli. So separate from this, that acts in the interstitium of the lung, the things that's happening between all these other parts. So there can be fibrosis and scarring in COPD. We see that not uncommonly, COPD with fibrosis. You can have fibrotic lung disease in severe cases of bronchiectasis. You can see scarring. It's not the main player, but it's not the driving factor behind a lot of the symptoms, but you can see some of that scarring. Other questions? Yeah.
Also, pulmonary fibrosis has been caused.
It can.
So how would you know which is being triggered off at the time?
Imaging. So and it really depends. If I have a patient that has both bronchiectasis and pulmonary fibrosis, sometimes it's hard to know what's the driving factor. Is it the fibrosis that's causing more of the cough?
Yep.
Is it more of the bronchiectasis? The cough in interstitial lung disease is usually a dry cough. This tends to be more productive. So patients are usually bringing up phlegm when it comes to bronchiectasis. ILD, interstitial lung disease, much more dry. But sometimes you can have both, and it can be difficult to discern the symptoms. Yeah. Dry cough with yeah, but no phlegm is coming out. It's just you're not expectorating.
What is that then, the dry cough?
Well, it could be in the question she posed. It's probably from interstitial lung disease. Yeah. You're welcome. Other questions? I know. Thank you so much. I appreciate it. Thank you.
Is there anything new on the horizon that's underway for COPD treatment?
There are newer treatments that have come out. There's an nebulized inhalation treatment called Ohtuvayre, which is a phosphodiesterase 3 and 4 inhibitor. You may have seen this injectable called Dupixent, and also Nucala have been approved for COPD to prevent exacerbations, to prevent lung loss. So that's what's new. There's always new things in trials and coming up, but nothing that's ready for prime time yet. Questions? Anything else?
I owed you there, and I'm guessing it made a big difference.
I get that a lot with patients.
Yeah.
Ohtuvayre makes a big difference, she said, in her case.
My insurance won't cover it, so it's like $846.
I know. That's the bane of our existence. Is what I tell these guys in the back. Great, I love your drug. I want to prescribe it, but it's not up to me. It's up to the insurance company. Lots of things that I would love my patient to have that they can't have because they can't afford it. Who's going to pay $800 a month for one drug? It's tough.
I also was approved for the Zephyr treatment.
Mm-hmm.
They took me in for the Zephyr, they put me under, and he couldn't put it in because my lung was too mushy.
Okay, it wouldn't take. Yeah, that happens sometimes. Yeah, that's unfortunate. Yeah.
Has there been any success with that?
In the right patient population, it can make a difference. They're talking about the Zephyr valves for emphysema. So what happens in this case is those areas of emphysema, they push on normal lung. It's like, think about if I put a balloon in your chest, it's going to compress the normal lung, so the normal lung can't function properly. So what these Zephyr valves do is it's a one-way valve that goes in the airway, and it kind of deflates that area of emphysema, and then the normal lung can expand and function more normally. So in the right patient, it can work very well. Yeah. And it's better than cutting out part of the lung, which is what we used to do.
In reference to those valves, why is no those valves effective for patients with pulmonary fibrosis?
So it's only for emphysematous lungs. So you have to have big balloons of emphysema in your lung. Fibrosis is just scarring, so there's usually no emphysema in those patients that have fibrotic lung disease. If you have both fibrosis and emphysema, and we believe it might work for just the emphysematous part of your lung, then yeah, you might be a candidate. But for pure fibrosis, no.
So with pulmonary fibrosis, you can have emphysema as well?
You can't have a combined pulmonary, it's called combined pulmonary emphysema and fibrosis. So usually emphysema is the driving force, but there is scarring that can be associated with in emphysema. It's not the fibrosis is not the major factor there, but it can be significant.
The only way you can tell that you have this fractal thing is by a CT
CAT
scan.
scan, yeah, yeah.
My other question is if the bottom of my lung is mushy, is there anything I can do so that it wouldn't be mushy?
I think probably I think what the mushiness is probably bronchomalacia. So it may be that those airways collapsed on themselves and they weren't able to get that valve in. So usually no, there's not much to do about tracheobronchomalacia per se. Yeah.
Does mast disease have any relationship or cause it? Like I
So-
have both.
Yeah, we frequently see bronchiectasis in MAC patients. Yeah. So with non-tuberculous mycobacterium, another chronic infection, patients can develop bronchiectasis. And we see it frequently. And the pattern of disease in non-tuberculous mycobacterium is typically middle lobe, lingula, kind of where, because this bacteria goes where the ventilation of the lungs is greatest. So when you inhale this bacteria, where does it usually end up? Usually going to end up in the upper part of the lung, or in the right middle lobe, or in the left side in what we call the lingula. So yeah, we see that commonly. Yeah.
I have a question about the drug itself.
Mhm.
In the drug itself, because it reduces your neutrophils, resulting in a reduced amount of fluid, basically, and then you get really dry, and you have an extremely dry mouth and things like that, and not too much has been said about that. Is that not a normal reaction?
Dry mouth with this drug?
Yes.
Yeah. Again, there's a warning about it because of that when we inhibit that DPP1 enzyme, that can lead to this gingival issue with this drug. But again, it's not very common. But if you're on the drug, you should be aware of it and make sure that your dentist or whoever takes care of your oral hygiene knows about it and does a proper exam.
But you're still dry. I mean,
Yeah.
what I wanted to ask is, when you first start on Bronchiectasis,
Yeah.
and then you get real dry, basically what happened to me is that I started with this extremely dry cough
Okay. On the Brinsupree?
on the Bronchiectasis.
Okay.
And so then I'm thinking, is it because there's nothing there to protect my lungs that haven't
No.
been before?
No,
I
no.
mean,
So
like the fungus,
because
not
it's,
the fungus.
so because you're blocking this activation of the neutrophil, it doesn't mean we're lessening the immune system of your lung and you're predisposed to other infections. So that's not necessarily what we're seeing. Yeah. So we're preventing it from releasing these serine proteases, which neutrophil elastase is one of them, and that sometimes too much of a good thing is a bad thing. And that's exactly what's happening in here, is that this neutrophil elastase is causing this destruction in your lung, and it's causing this perpetuation of the bronchiectasis and the inflammation and all that. So we try to limit that, but it does not necessarily mean that it's going to limit your lung defenses. So that won't happen.
So my just question was, is that you're now getting air where there wasn't any air. So now you may be feeling it more and wanting to cough more. That's all I was.
No, you're not going to get air where there is. What we're doing is we're limiting you from having an infection. We're preventing the loss of lung function. This is not like a bronchodilator that's opening up airways and things like that. It's preventing that inflammatory cascade that will, down the road, limit you from having an infection and limit the rate of lung loss that can happen with this disease. But it's not a bronchodilator in any way.
That wasn't what that's
Yeah,
right.
okay.
Anybody else?
Anything else? All right, well, I appreciate you all coming and having me here. Good to see some of you. Okay. Thank you very much.
Thank you,
All right,
everybody.
thanks.
Thank you, doctor.
You're welcome. You're welcome. Oh, that's right. I'm gonna walk out.
Thank you, doctor.
Well, thank you, everybody. We really do appreciate, Doctor. Thank you very much again. I want to remind everybody that we are going to try to have these meetings every month from every topic possible we have, especially that is related to our lungs. A lot of this disease that we've seen are related one to the other. So if anybody has any topic or anything that you want to know, by all means, let me know. Let me know on the webpage, let me know on the email. And is everybody receiving my emails? Okay. There is a sign-in sheet. Yes. Please have the email there, so you will be receiving all the emails every month and all the information that I will always put on.